Hi everyone, just quick announcement. Hello, okay. Firstly, in preparation for our end of course practical exam, PathStock is holding a pathology tutorial that's aimed for our end of course prac exam, which is like 5 days after our end of course exams. So that's tonight at Walsworth ground floor, starting at 5:30 p.m. And the second announcement is, if anyone is free to be a mock patient for mock ICE, please also go to Walsworth. It's in like the normal area, and that's for preparation for phase 2 students who have their ICE exam soon. And lastly, we know that so practical exam is on the 18th, and Evan and I are thinking everyone who is free go to Coogee Beach afterwards, and we'll have a grade photo there. So just keep that in mind. Okay, thank you.
Okay, I think we may just start now. Okay, so we come to today, and this is our very last anatomy lecture for this course, which I don't know whether it's a good thing or a bad thing, but yep, it's the last anatomy lecture. Today's lecture is going to look at the nerves and vessels of the nerves of the lower limb, and so we're going to concentrate a little bit on the lumbosacral plexus, and from the plexus you'll see that there is really a large number of nerves that come off and supply the lower limb, but by and large there's 3 main nerves that I want you to concentrate on, and I've labeled those 3 there. So as we go through the notes, I may mention some other nerves just for completeness, but these are the 3 main nerves that you should actually remember and study. There's actually one other, the gluteal nerves, which I'll talk about just now. Okay, and then related to the nerves, obviously we want to relate them to injury, and so when we talk about injury, we want to understand what is the functional deficits of those nerves and nerve lesions that can happen. Okay, so I thought just before we even start with the nerves, I'll just talk about a little bit about the gateways to the lower limb. So by now, this kind of diagram is kind of familiar to you. We're looking at the pelvic girdle, and we're looking at the femur. So we're actually looking at the point where the lower limb begins. From this pelvic girdle, there's a whole lot of structures that actually pass to and from the pelvis into the lower limb. So this is where we have a few entrances and exits. So I thought I'll just label those for you. The first one here is the inguinal ligament. The inguinal ligament is passing anteriorly from the anterior superior iliac spine to the pubic crest, and underneath the inguinal ligament there's a whole lot of structures that can pass through. I don't want you to know the list of structures. Like I said, I put that list up for completeness. I'll highlight the ones that I want you to know during the lecture. But just remember that there is the inguinal ligament, and under the inguinal ligament a whole lot of structures will pass into the lower limb. Likewise, if we look really towards the back posteriorly, there's 2 ligaments that we've done before, the sacrotuberous ligament and the sacrospinous ligament. Remember, the sacrotuberous and sacrospinous ligaments are from the sacrum to the ischiotuberosity and the ischiospine respectively. Now those 2 ligaments actually also complete 2 foramina. They will complete the greater and the lesser foramina that you can see in pink and in blue. Now these 2 foramina that are formed by these ligaments are actually a major exit and entry point into and out of the pelvis. So we'll also be talking about structures that lead there. Now for us and in this course, by and large, we don't do much with the lesser sciatic foramen, but we do talk about the sciatic nerve that actually passes through the greater sciatic foramen. When we speak about the greater sciatic foramen, there was also a muscle that passes through that foramen. Who knows what muscles that is? Good, excellent. You all can read the slide. So it is piriformis, right? So that is the muscle that passes through. So if you remember piriformis, just to recap a little bit, it is the muscle that actually arises here from the anterior surface of the sacrum, and then it will pass through the greater sciatic foramen to end up in the gluteal region. Okay, and then the last gateway that I actually want to highlight to you is here we have the obturator membrane, but in the upper part of the obturator membrane there is a little deficit or a little foramen, and that foramen actually forms the obturator canal for our obturator nerves and vessels. Okay, so those are the three main gateways that we actually talk about when we talk about the lower limb. Now when we talk about nerves of the lower limb, we're going to talk about nerve injuries, and nerve injuries can be roughly divided into two types. There's peripheral nerve injuries, which you came across before. So when we spoke about the brachial plexus and its branches, we spoke about lesions to the median nerve and the ulnar nerve and the radial nerve and all of those things. Those are peripheral nerves. So by and large, when we have a lesion of the peripheral nerve, what happens is that all the structures that are supplied distal to that nerve becomes compromised. So all the structures distal to that nerve injury will become compromised. So in a peripheral nerve injury, that is probably the most significant difference that we should note. The other thing is because peripheral nerves carry in them more than one spinal cord segment fibers, we generally have total muscle function loss that's distal to the lesion, and we'll also have sensory loss to the structure supplied distal to the lesion. Okay. Whereas when we look at a nerve root lesion, and that's what I'm showing you in this diagram, there's a normal disc and there's the nerve roots coming off from the vertebral column or from the spinal cord. So these nerves, if you look here we have a lesion of the nerve root itself, and you can see this lesion is a herniated disc, and the herniated disc is compressing the nerve root. Now because this nerve root injury is only affecting one nerve root, that means that the effect of that lesion is not as drastic as the peripheral nerve lesion. So we will have muscle weakening because usually the muscles are supplied by more than one spinal cord segment. So we'll have weakening of the muscle but not loss of muscle function. And similarly, when we look at the sensory innervation, we may have loss of sensation over a dermatome, so an area of skin supplied by a single spinal cord segment. Okay, so those are the two big differences when we talk about peripheral nerve lesions and nerve root lesions. So just keep that in the back of your mind as we talk about this. So today we're going to talk about the lumbar plexus and some of its branches. So if you look here, this really complicated mass of nerves that we are looking at here is called the lumbosacral plexus. The lumbosacral plexus is the ventral rami from T12 all the way down to about S4. For our sake, just to make things simple, we kind of divide the plexus into a lumbar part and a sacral part, and so that's what I'll do just now. But actually, when we look at it anatomically and functionally, they're kind of united together. Okay, so we're going to look at all of that and try and unravel it. Now, like I said before, there's a whole mass of nerves here, and you don't need to know all of them. I'll highlight the ones that you do need to know. So if you go back and look at it in a really simple way, if these are the vertebral bodies, and those are the intervertebral discs, we have the nerves that come off each spinal cord segment, and coming off L1, we have ventral rami, and those ventral rami form two nerves that we call the iliohypogastric and the ilioinguinal nerves. You may have come across this before when you did HMA or B. You may have come across them before, so those are really a kind of revision. And these nerves will supply the buttock and the pubis and the anterior thigh and the perineum. We're not really too concerned about them. There's a little bit of supply to the lower limb from the ilioinguinal nerve, but by and large we're not too concerned about them today. The next nerve that comes off the lumbar plexus is a nerve that comes off L1 and L2, and it joins to form the genitofemoral nerve. Now the genitofemoral nerve, you can see it has two parts to it. It has a genital part, which again we're not concerned for today, but it does have this femoral branch. This femoral branch that it has will actually pass with the femoral sheath, which is encasing the femoral vessels, and it will enter the thigh and it will supply that skin over the femoral triangle. Where would I find the femoral triangle? Yes, so it's anterior to your thigh, just inferior to the inguinal ligament, right? We're going to talk about that just now, but the area of the skin of that femoral triangle is supplied by the femoral branch of the genitofemoral nerve. So those are two branches, and like I said before, we're not concentrating too much on them, except to know that the skin over the femoral triangle is innervated by the femoral branch of the genitofemoral nerve. The next nerve that comes off is called the lateral cutaneous nerve of the thigh, and the lateral cutaneous nerve of the thigh, like its name suggests, will supply the skin on the lateral side of the thigh. Now, you're not going to have to identify these things in specimens, but you are going to have to actually have a knowledge of the cutaneous innervation of the lower limb. So the lateral cutaneous nerve is going to supply the skin on the lateral side. The next set of nerves, there's actually two of them that come off from L2, L3, and L4. All of the anterior rami that you see in green will actually join and they will form the obturator nerve. And the posterior rami will form the femoral nerve. So they're both coming off L2, 3, 4. The anterior divisions join to form the obturator nerve, which will supply the adductor compartment or the medial compartment of the thigh, and the posterior divisions will join to form the femoral nerve, which will supply the anterior compartment of the thigh. Now remember, the reason why the posterior divisions are supplying the anterior compartment of the thigh is because in embryology the lower limb has rotated such that that posterior surface or the dorsal surface came to lie anteriorly. Remember? Okay, good. And then the last branch that comes off the lumbar plexus is actually a trunk. It's called the lumbosacral trunk, and it's formed by L4 and L5. And this trunk, or via this trunk, we actually then join the sacral plexus. Okay. So the sacral plexus, is what we're going to talk about just now. There's a mnemonic to remember these branches if you want a mnemonic. I'm sure you can find a more interesting mnemonic that you would find very soon, but that's a mnemonic to remember the branches in order as they come off. Okay. Now remember I said mnemonics later. Okay. Remember I said that the L4, L5 forms this lumbosacral trunk, and this lumbosacral trunk then joins the lumbar plexus to the sacral plexus. So if you look at the sacral plexus from S1, 2, and 3, we also get the rami that come out, and all of these rami combine with the lumbosacral plexus, and they form this huge nerve, the largest nerve that we have in our body, and that is called the sciatic nerve. Now the sciatic nerve is the only branch of the lumbosacral plexus, of the sacral plexus, that I want you to concentrate on for now. Everyone good with that? No? Okay, so this is the lumbosacral plexus. We went through the lumbar branches, and I told you the main branch of the sacral segments that I want you to know is the sciatic nerve. The sciatic nerve is formed by L4 to S3. You can see that L4 via the lumbosacral trunk all the way down to S3. Okay, so now we're going to start looking at these nerves individually and see what they do in the lower limb. And part of this is actually a way in which you can revise what we've done in the lower limb thus far. So if you look here, like I said in the very first lecture that I gave you when we were talking about nerves, a very nice way to actually remember the stuff in the limbs is to actually think in terms of compartments. So if we look at this really simple diagram here, it is a cross-section of the thigh, and it is showing you the thigh compartments. The bone in the middle here would be the femur, and so the thigh compartments can be divided into three parts by the fascia. There's an anterior compartment in which we would have what kind of muscles? The quadriceps muscles would be one of our muscles here, right? So that's in the anterior compartment. In the medial compartment, we would have what group of muscles? The adductors, right. And in the posterior compartment, what group of muscles will we have? The hamstrings. Good, excellent. You're ready for the exam, I think. So if we look here, and if we remember these compartments, the innervation of the thigh largely follows these compartments, except for one or two exceptions. The anterior compartment is supplied by the femoral nerve, which I just showed you came off L2, 3, 4 posterior divisions. The posterior compartment here is supplied by the sciatic nerve, and we'll talk about that in a little bit more detail. And the medial compartment is supplied by the obturator nerve, which is the anterior divisions of L2, 3, 4. Everyone good with that? Good. So let's just uncouple all of that, and if we just look at the obturator and the femoral nerves, both of these nerves are coming up L2, L3, and L4, like I told you just now. The posterior divisions form the femoral nerve, the anterior divisions form the obturator nerve. I'm really stressing that because students actually mix them up. The posterior is actually anterior in the thigh because the femoral nerve is supplying the anterior compartment of the thigh, but it is formed by posterior divisions because of the rotation of the lower limb. So now if we look at that, what happens with the obturator nerve? It comes off the anterior divisions. Then you'll see it passes through the pelvis, and when it passes through the pelvis, it lies on the lateral wall of the pelvis. So if you look here, you'll see it's lying on the lateral wall of the pelvis, and eventually it will pierce, or it will pass through that obturator canal, and it will then end up in the medial compartment of the lower limb, of the thigh. Okay, so obturator, anterior divisions, passes on the lateral wall of the pelvis, passes through the obturator canal, and then comes to lie in the medial compartment. And when it comes to lie in the medial compartment, it will supply all of the muscles in that medial compartment, which is the adductor muscles. We've done all of these muscles except for the one that I've grayed out, so you should be able to know where these muscles are. Now, I've got there an asterisk next to adductor magnus, because just to recap, remember adductor magnus has two parts. It has an adductor part and it has a hamstring part. So this part here that is supplied by the obturator nerve would logically be the adductor part that is supplied by the obturator nerve. Remember, the adductor part is the part that is actually attaching onto linea aspera, but the hamstring part is attaching onto, where does the hamstring part attach on the femur? Adductor tubercle. It will attach onto the adductor tubercle. Remember? It was in the spot in the prac last week. Okay, so let's just look at the femoral nerve then a little bit. So the femoral nerve is coming off the posterior divisions of L2, L3, L4. It passes through the pelvis as well, but as it passes through the pelvis, it passes underneath the inguinal ligament. Remember, underneath the inguinal ligament, and then it will enter this region here, which is exactly the same region as the femoral triangle. So it is a content of the femoral triangle. So femoral nerve comes off the posterior divisions of L2, L3, and L4, passes through the pelvis, and then enters the thigh by passing under the inguinal ligament. Once it enters the thigh, you would find it as a content in the femoral triangle. Everyone good with that? And then, of course, it will supply all the muscles of this anterior compartment, and I've got a whole list of muscles that you see there. The ones that you're most familiar with is the quadriceps, but it also supplies the iliacus part of iliopsoas, sartorius, and pectineus. Okay. So let's just look at that femoral nerve a little bit more. So if we look at the femoral nerve, I told you where it comes off. It is the largest branch of that lumbar plexus. Don't confuse lumbar sacral plexus with lumbar plexus, but from the lumbar part of that plexus, it is the largest and the thickest branch that you would find. It passes underneath the inguinal ligament, like I told you, and it will be a content in the femoral triangle, and we'll revise the femoral triangle just now. But in terms of its distribution, if you look here, I want you all to also have a look at the cutaneous distribution of the femoral nerve, and the cutaneous distribution of the femoral nerve is to the skin of the anterior thigh, and then as it passes downwards, it passes medially to supply skin on the medial aspect of the leg and foot. Okay, anterior medial aspect, that is. Okay, so if we just revise a little bit of the femoral triangle, sorry, that's exactly the same thing I'm telling you again. So here's the inguinal ligament, remember? That is the superior border of the femoral triangle. The lateral border of the femoral triangle is formed by sartorius, and the medial border is formed by adductor longus. On the floor here, we would have iliopsoas, we'll have pectineus, and we'll have adductor longus. Okay, so the contents of the femoral triangle is the femoral nerve, the femoral artery, and the femoral vein. The femoral nerve is the most lateral structure in that triangle. Okay, this is a cadaveric specimen of exactly the same thing. So here is the inguinal ligament. This here would be sartorius. Sorry, the opposite way. This here would be sartorius, and this here that is cut is adductor longus. Underneath, through the cut part of adductor longus, you can actually see adductor brevis. Okay. Just out of interest, this muscle going down here would be? Excellent. You are ready for the exam. See. So that is femoral vein, femoral artery, and femoral nerve. Okay, so I told you what the femoral nerve supplies. It is the main nerve to our anterior compartment of the thigh. So if you have an injury of the femoral nerve, what do you think would happen? Most significantly, and the thing that would be most obvious. Yeah. So it'll affect extension of your leg, isn't it? So you would lose knee extension, and you wouldn't be able to stand upright. So the person will actually appear as if they're buckling over. So that's the main thing. You have loss of knee extension. You'll also lose some of the knee reflex. So if you remember the knee reflex, it's where you're tapping the tendon of quadriceps, and that will cause tapping the patellar ligament, and you're causing the knee jerk. So you'd lose the knee jerk reflex. And of course, you'll use cutaneous distribution over that area that is colored green that you can see here. Okay, so usually femoral nerve lesions will occur from trauma, so some kind of extreme thing like a stab wound in your thigh, but also trauma that may affect the bone that will cause a lesion of the nerve. The next nerve that we're looking at in a little bit more detail as well is the obturator nerve. Again, the obturator nerve, anterior divisions of L2, L3, L4. I told you that it passes along the lateral wall of the pelvis, and that's probably where it is most susceptible to injury, and then it will pass through the obturator canal to come and lie medial in the thigh. Okay. If you look at its cutaneous innervation, you can see that it supplies a strip of skin over the medial compartment of the thigh, and that would be its cutaneous distribution. So if you look here in this diagram, what I just wanted to show you, if you look highlighted in green, that is where we actually see the obturator nerve in the pelvis, and this is where it actually becomes susceptible to injury, especially during pelvic surgery. So this is the one structure that lots of care is taken to actually identify and keep out of the way of the surgical field. So what would happen if there's a lesion of the obturator nerve? Yeah, so the person wouldn't be able to adduct their lower limb. So adductors will be paralyzed. Okay, then just to move on, if you remember when I did the gluteal region, I mentioned this to you then, and I'm just recapping that here. So if you look here, this muscle here that we're looking at is piriformis, and piriformis is the landmark in the gluteal region because it is the structure that is used to identify all of the structures. If you look here, there's a nerve passing above piriformis, and there's a nerve passing below piriformis. The one passing above piriformis is called the superior gluteal nerve. It's from the sacral plexus. And the one that passes below is the inferior gluteal nerve, also from the sacral plexus. You can see here that as the superior gluteal nerve comes off, it will immediately pierce the green muscle, which is
Gluteus maximus? Medius.
Who says it's gluteus maximus?
Medius.
Who says it's gluteus medius? Fantastic. It's gluteus medius. So as it comes off, it immediately pierces gluteus medius, which it would supply, and it will also supply gluteus minimus. So this is the superior gluteal nerve. Superior gluteal nerve. The L is missing on the slide there. But it is going to supply gluteus medius and gluteus minimus. The inferior gluteal nerve, as it comes off here, it passes upwards, and the big bulk of muscle that is sitting right over there is gluteus maximus. So the inferior gluteal nerve will supply gluteus maximus. Okay. Now, those are the two main nerves that we're going to see in the gluteal region. And the last one that you can see coming down here, this big nerve, and it's probably the thickest and the longest nerve in your body. Not probably, it is the thickest and longest nerve in your body. That is the sciatic nerve. The landmark for the sciatic nerve, again, is that it passes below piriformis. Okay. In this diagram here, you can see that the sciatic nerve has actually divided into its two parts, but often when you look at it in the anatomy lab, you'll see that it is actually one structure until some time in the thigh where it will divide. So here it's divided, but doesn't always divide so high up. So that is the sciatic nerve. I spoke to you a lot, I think, when we spoke about the gluteal muscles. We spoke about the Trendelenburg sign and how that works. So that is a direct result of a lesion to which nerve? To the superior gluteal nerve, which is supplying gluteus medius and minimus, because those are the muscles that is actually responsible for keeping the pelvis in line when you're walking. So when there's a lesion of the superior gluteal nerve, what would happen is that we would have this pelvic tilt, okay, on the opposite side. Okay, so let's talk about the sciatic nerve a little bit more. So if you look here, the sciatic nerve, I told you already, thickest, longest, coming from L4 to S3. As it comes off, typically it will pass through the sciatic foramen, and then in the gluteal region, you would usually see it inferior to the piriformis muscle. It then passes downwards in this arc that you can see here, and sometimes as it passes down in the thigh, it will divide into its two branches, which is the common fibula and the tibial nerve. Some people also will say common peroneal. You can use the words interchangeably. Okay, so again, sciatic nerve L4 to S3 passes through the gluteal region and enters it via the greater sciatic foramen, underneath piriformis, and then down the thigh. If you look at sciatic nerve, you'll see that the sciatic nerve, because it divides into the common fibula and the tibial nerve, it ends up through those nerves supplying all of the structures distal to the knee. Yep? Okay. So because it divides into those two branches, and via those two branches, it supplies everything distal to the knee. In addition to that, it supplies the hamstring muscles. So if you look at the hamstring muscles will be in the posterior thigh, and as this nerve passes in the posterior thigh, it will supply the hamstring muscles. The way it does that is that the common fibular nerve supplies the short head of biceps, and everything else is supplied by the tibial nerve in the hamstrings. Okay, and then the last thing that I want you to have a look at here is the sensory distribution of the sciatic nerve, and you'll see the sensory distribution is along the entire posterior thigh and leg. For that reason, when someone complains of sciatic pain or sciatica, you'll see that they have tingling along the entire posterior aspect of their lower limb. Okay, so exactly the same thing I'm telling you here. So it passes through the greater sciatic foramen. Here we can see it under piriformis, then passing deep into the thigh, where it will divide into its two parts. Okay. Now, remember I said just now the sciatic nerve actually is found inferior to piriformis, and that's what you're looking at in this first diagram. That's its classically described relationship, that it passes inferior to the piriformis muscle. But you can see here that in a significant number of people, the sciatic nerve may actually pass through the piriformis muscle. Now, when it passes through the piriformis muscle, that's when there is a group of people that is susceptible to what we call the piriformis syndrome. Every time the muscle contracts, it actually squeezes on the nerve itself. That's the piriformis syndrome. And in a number of people, it can also pass over the piriformis muscle. Okay, sciatic nerve injury. It used to be that the most common way in which the sciatic nerve was injured in the past was through gluteal or intramuscular injections that were given incorrectly, and for that reason the safe area for gluteal injections has been identified as the outer quadrant of the gluteal region to avoid the sciatic nerve, and also to avoid the superior and the inferior gluteal nerves that come off here as well. Okay, so that's the safe area. Obviously, if we have a lesion of the sciatic nerve, what would happen? Yeah, you won't be able to flex your knee, isn't it? Because I told you everything distal would be the sciatic nerve, so you'll lose knee flexion. You'll also end up with what we call foot drop. So foot drop is exactly like wrist drop. It means that the foot, you won't be able to dorsiflex, but lift your toes towards the ceiling. Your foot will just lie downwards. Fine. And people who have foot drop, what they tend to do to avoid the dragging of their feet on the floor as they walk, they tend to have a high step. They lift their legs extra high to take that step. Okay, so that's foot drop. Okay, and sciatica, I told you about just now. Sciatica can sometimes happen over the entire sciatic nerve, but it also can be just related to a particular nerve root, and so you would have compression along that particular dermatome, or you'll have sensation along that particular dermatome. Okay. So I just wanted to also talk to you about the leg and the innervation of the leg. So this diagram looks a bit busy, and I should have made it simpler, but anyway. So if we look here, this is a cross-section of the leg, and the two bones that you would find in the leg would be the tibia and the fibula. The leg is also divided into three compartments by the fascia. It's divided into a posterior compartment, a lateral compartment, and an anterior compartment. The anterior compartment is supplied by the deep fibular nerve, and the lateral compartment is supplied by the superficial fibular nerve. This superficial and deep fibular nerves are branches of the common fibular nerve, and we'll talk about that just now. And the posterior thigh is supplied by the tibial nerve. Like I said before, again, it's actually easier to understand the innervation if you think about compartments, because then you're not learning individual muscles and the innervation, but you're learning a group of muscles, and the function is actually related to the innervation as well. So if we look at the common fibular nerve quickly, here's the common fibular nerve. It comes off the sciatic nerve actually divides into the common fibula and the tibial nerve. It does this posteriorly in the thigh, and as it divides into the common fibular nerve, you'll see that the common fibular nerve winds around the head of the fibula or the neck of the fibula to come and lie anterolaterally. So common fibular nerve comes off posteriorly, but as it comes off, it winds around the fibula to come and lie anterolaterally. And so here it divides into its two branches. The dark green branch, which is the deep fibular nerve, and the light green branch, which is the superficial fibular nerve. The common fibula winds around the fibula and then divides into its two branches. Okay. The deep fibular nerve is supplying the anterior compartment, so it's supplying all the muscles that lie anteriorly, and the superficial is supplying the two muscles that lie in the lateral compartment. Everyone good with that? Okay, so if we look at the tibial nerve, what's happening with the tibial nerve is that it also comes off the sciatic nerve posteriorly. The tibial nerve is the nerve that you'll find passing almost straight down. It passes through the popliteal fossa, and then it passes into the posterior compartment of the leg. One of its important branches is the sural nerve, which you don't have to know, but just out of interest. And the tibial nerve then supplies all of the structures in the posterior thigh, except for the short head of biceps, which is supplied by the common fibula, but otherwise it supplies all of the hamstring muscles, and it will also supply the posterior muscles of the leg. Now remember, when it supplies the hamstring muscles, it will also supply that hamstring part of adductor magnus. Okay, and this hamstring part of adductor magnus is coming off like the rest of the hamstring from the ischial tuberosity, and it's the part that attaches onto the adductor tubercle. Is everyone with me in this room? Okay, and through the tibial nerve we also innervate all of our foot muscles, and we're not going to talk about the foot muscles today. Okay, good. So let's just look at that in a little bit more detail. I told you that if you look at the posterior thigh, that's where you'll see the sciatic nerve dividing into the common fibula and the tibial nerve. Now here I've got a diagram of the popliteal fossa, and if you look at the popliteal fossa, you'll see that we have a few muscles. On the medial side of the popliteal fossa, we have semimembranosus in blue, and in red, semitendinosus. Right. Remember, semimembranosus is passing medially, and it will insert onto the tibial condyle, and then it will be reflected as the oblique popliteal ligament. Remember vaguely? And the semitendinosus actually passes downwards and attaches medially in line with sartorius, gracilis, and semitendinosus in a common tendon that we call the pes anserina, or the goose's foot. Right. So that is where we are medially. Laterally here, what would be the lateral border?
Biceps femoral.
It will be biceps femoris, isn't it? So this here, sorry, I should have said this is lateral and this is medial. Obviously that's superior, that's inferior. Okay, and then the muscles that are forming the inferior borders are the medial and lateral gastrocnemius. Okay, so if we look here, can you see the nerve that is passing straight down in orange? This here, sorry, this orange nerve, that will be the tibial nerve. It passes straight down, and as it passes straight down, it actually enters the posterior compartment and then supplies the muscles there. It divides into two branches there, but we don't need to worry about that. And the superficial, or the common fibular nerve, is passing down here, and as it passes, it winds around the neck of the fibula and passes anterolaterally, where it will divide into the deep and superficial branches. The superficial branch for the lateral compartment and the deep for the anterior compartment. So if you look at a deeper dissection here, you'll see exactly what I was showing you there. There's the tibial nerve, but what you can see more clearly now is the common fibular nerve that's winding and going to lie anterolaterally. Okay, I've told you all that, so I'm not going to tell you that again. Okay, so if you look at the common fibular nerve, remember I said the common fibular nerve, as it passes around, it winds around the neck of the fibula, and as it winds around the neck of the fibula, it becomes vulnerable to injury, firstly because it's lying subcutaneously and it's lying against the bone, and secondly, in just about every sport injury, when people get injured on their lower limb, they normally get a blow to the lateral surface of their knee. Very unlikely that they will get a blow to the knee, medial surface of the knee, but when they get a blow to the lateral surface of the knee, then this nerve actually becomes vulnerable to injury there. So this is probably where it is most easily damaged. So that is the common fibular nerve. But also, as the nerves pass into the compartments, there is what we call compartment syndrome, and compartment syndrome can also cause compression of each of these branches in their respective compartments. More vulnerable in the anterior compartment because injuries that are anteriorly can cause a lesion of the blood vessel that can cause anterior compartment syndrome in the anterior compartment. Okay, so if you look at the tibial nerve, here is the tibial nerve, passes downwards, and like I said, straight into the popliteal fossa, and as it passes into the deep compartment, you'll actually find it underneath soleus. So if you look underneath soleus, you will find the tibial nerve. The tibial nerve also runs close to bone, and as it passes down, it passes behind the medial malleolus to enter the foot. And as it enters the foot, it will divide into plantar nerves that will supply the foot muscles that we're not going to worry about too much for now. But remember that because of this, injury of the tibial nerve can actually result in loss of plantar flexion and also loss of flexion of the toes. Did I just tell you this? I think I did. Okay. Oh, yeah, so I'll just tell you this here as well. The deep fibular nerve, remember we said that it passes into which compartment? The anterior compartment. And as it passes into the anterior compartment, it passes downwards and it passes anterior over the ankle joint. For this reason, when people use ill-fitting shoes, especially ski boots, which have been implicated in this, and also dancing shoes where they actually have a tight band over the front of the shoes, they end up with what we call a ski boot syndrome, and this is really an injury of the deep fibular nerve, and this will result in foot drop as well. Okay. Why do I have these things twice? Who knows? Okay, and I've given you a summary of this common fibular nerve and how it actually divides and what muscles it supplies, just to make it a little bit easier for you, and the same for the tibial nerve. Because I find sometimes just drawing a sketch actually makes things a little bit easier for me to understand. Okay, and then the last few things that I wanted to tell you is remember we spoke quite often about this concept of dermatomes, and dermatomes is the area of skin supplied by a single spinal cord segment. But very much like dermatomes, we have myotomes, and myotomes refers to a group of muscles that are supplied by the same spinal cord segment. So you will find that in the limbs that this spinal cord segments actually supply certain muscles that move joints in particular ways. So we'll have, for example, for hip flexion, we have L2, L3. Those are the spinal cord segments that supply the muscles that will cause flexion of the hip joint. And I've given you the others here. It actually is handy to remember because that's how we actually test for nerve root lesions, by looking at the movements of these joints. There's a useful little nursery rhyme that you can actually use to remember all of these different myotomes, and I think we've had it in the prac a few weeks ago as well. Okay, so I thought just to finish in the last 15 minutes, we'll actually do some examples. So have a read of that and let's see if we can work it out. Where would you palpate the fibula? You can do it on yourself right now. Where are you feeling? You're feeling laterally, isn't it? Anterolaterally. Okay. What structure is related to the fibula in this region? From today's lecture, to give you more perspective, what structure is related to the fibula in this region? The common fibular nerve. And what is the possible effect of an injury? We just did it now. It will be foot drop, isn't it? Yep. Just remember the common fibula is supplying the anterior and the lateral compartments, and because of that you won't be able to dorsiflex your foot. Okay, a second question. Oh, there's the answer there. Oh, that sounds painful, but what is the answer? Which ligament is actually going to be injured? Which ligament prevents anterior displacement and which ligament prevents posterior displacement? We're talking about cruciate, but which one? The anterior cruciate ligament, right? The anterior cruciate ligament prevents anterior displacement. The posterior prevents posterior displacement. What other ligaments may be injured? Okay, I'll leave you with the rest of it. Let's do the next one. So what nerve are we thinking about? Good, and it comes from L. A basketball player sprains his ankle and he complains of pain on the lateral side of his right leg. You'll do that, isn't you? Hey, we'll stop that, and that's the end of our anatomy lecture.
三个是怎么会有这么多货？这个是 ventral remind， 这个是 dorsal remind， 怎么会一个字上有三个人？它不是 remind 也有这个有，我就问你，上面的。没有。But I thought Sophia had the yeah, it's really confusing.
Oh yeah, because so what happens is the nerve comes off like that, and it comes here, and we have anterior and posterior.
Yes.
So we were talking about the anterior division. The anterior division here divides into three branches.
So all of them are actually ventral.
Yeah, all of it. We don't talk about dorsal vena at all, because remember dorsal vena only supplying the deep muscles of the back. So here we all talk
But
about
I do remember you mentioned some like one of them is the anterior branch.
No. So here, when we're talking about the femoral nerve, so it's all anterior. It's all anterior rami, right? But what happens here at the L2, 3, 4, that anterior rami divides into two divisions, an anterior division and a posterior division. The anterior division, so if you look here, so if I go to say L2, so it will have the dorsal and ventral vena, dorsal vena,
So we don't
ventral.
consider that.
Very concentrating here.
Yeah.
And these will give you an anterior division and a posterior division. Both at the level of L2, L3, and L4. All of these anterior divisions will join.
Yeah.
L2, 3, 4, and that will be the obturator nerve.
Yeah.
And all of the posterior divisions for L2, 3, 4 will join, and that will be the femoral nerve.
Yeah, just want to know.
Yeah.
Because it's a bit confused why we have to It's okay.
Oh, sorry. Yes, thank
Thank
you.
you so much.
Okay, you're welcome. If you
This
have
is-
any questions, email me.
Okay, this is the last. Oh, we don't have that. Oh, we have that.
Oh, yeah, yeah. The last.
Finish.
And then it's over. Last exam.
Thank you.
Okay, you're welcome. Okay, then. Bye-bye.
Thank you. 说牛角尖啊，所有这些乱七八糟全都是 ventral，那么就是说它 ventral 到什么地方的时候有分支嘛，不是比如说这个就分成了这个，这个就分成这个，然后
它这不一定代表它就是几个distinct one，它就是说它的这个 ventral rim，
反正一个 ventral rim 分成多少支，然后多少支，然后同一个 spinal nerve 的 ventral rim 出来变成 anterior。
它就想让你知道 L1 的 ventral rim 有一部分是一部分 L1 的另外一
对
另外一部分是
然后这个又变成一个变成 anterior， 一个变成 posterior branch， 然后那些什么 anterior
变成 anterior，
这三个，然后2、3、4，2、3、4，他讲了嘛，那这里出来以后，这是 ventral rim， 这是 dorsal， 然后 ventral 变成了 anterior 和 posterior division。
那这是哪个？
这个是 anterior division， 然后就变成 obturator， 然后剩余的 posterior， 然后就变成 femoral， 剩下的可能又是什么什么 branch 就变成了这种，它讲不重要。又有的学了，其实不是太复杂。
比如说啊，肯定有一个很多 breakthrough lesson，
肯定，因为到时候 OK 问你摸。不错啊，小哥，不错，明白。进展很快。我不懂，我也不懂。坐楼台呀，没有，马上。Wow!